Assalamualaikum and salam sejahtera. Good evening, everyone, and thanks to Novartis team for having me here tonight. During this 20-minute session, I will try to dissect the issue of how and why we need to optimize the treatment strategy for our patients and to look at the impact or burden that we have to go through on the healthcare as well as to the patients. The reason why treatment of diabetic macular edema is potentially a long-term burden for us is because the disease itself is a chronic disease. A lot of our patients are not extremely well. They have concurrent systemic illnesses. Patients require frequent injections, not only for one eye, but half of them require injection or treatment to both eyes. And there is also an issue of cost involved, either the cost of the injection itself, and also losing their income is another indirect cost issue that we have to deal with. Now, when we look at the options of treatment, it's known to us that there are a few options. We have this fixed regime, which is not being used in our clinical practice, mainly in the RCTs. But then we have this option of treat and extend as well as the PRN basis. Now, a bit of detail on the treat and extend for DME. For treat and extend, we inject them monthly for 3 months minimum, which may continue up to 5 to 6 months until we achieve a normal consecutive OCTs and slowly start to extend their follow-up to 2 to 4 weeks with a compulsory injection and double up their follow-up on the subsequent visit if the OCT remain stable. Now, then we have the PRN mode of treatment, whereby we give them again a monthly injection of minimum of 3 months, which will also still continue up to 5 to 6 months if they continue to show some improvement until we have achieved a stable OCT changes or improvement or stable vision. After that, we call them back for every 1 to 3 months and only inject when there is recurrence of the DME. Now, just a quick recap on how the treat and extend and PRN differs from the fixed regime is mainly the advantage that we are getting. Giving treat and extend will help to reduce the burden of injection, in which less number of visits, and as well as giving us more or less a comparable result to the fixed schedule. Again, the detailed result of the comparative study between the treat and extend and PRN. This is from the retain study. At the end of 24 months, the treat and extend was found to be non-inferior to the PRN regime. So in other words, the mean number of injection was 12 injection for the treat and extend group, a little bit more compared to the PRN group, but it gives us a 46% reduction in number of the clinic visit. So with time, this is a very important information that we have to share with our patient. Most you are going to tell the patient that with time, the number of injection reduces every single year. Now, when we look at the reason why we are not able to replicate the RCTs are mainly because we do have a lot of variability in our patients' adherence and compliance. Now, when we look at real-world evidence, looking at the comparison between the treat and extend and the PRN treatment regime, of course, we are able to reproduce most of the RCT results, but at the same time, it shows that not only we are able to achieve less number of visits, but in actual fact, a lot of our patient has better vision and better OCT changes or resolution of OCT in the treat and extend group compared to the PRN group. Although the treat and extend will have a little bit more number of injection, but the number is more or less insignificant. Again, another study which also found the same outcome at 24 months, in which we have a better vision with treat and extend regime, as well as less fluctuation of DME changes on OCT. Now, this is the reason why I was asked to join the meeting tonight, is because to share the result of our study in UKM. We managed to complete a retrospective study in our center at how the treatment regime in our center affect the patient in our clinic. This is a list of our team members, mainly from the retinal team. And the study was actually conducted a couple years back, and it was completed in 2021. It was just last year. So the primary objective was to look at the treatment burden of DME as well as AMD patients. We look at the number of anti-VEGF injection in patients who at least completed 12 months of follow-up. Now, we also have secondary objectives. So we don't only look at the treatment burden, which are the number of injections given, as well as the number of visits to the clinic. We also look at the response of the DME towards the injection based on the CST or the OCT, and also the visual changes of the patient. And we also look at the how many of our patients who actually completed the loading dose, and also the discontinuation rate among our patients. Now, based on the inclusion criteria, we include patients who receive at least one anti-VEGF injection between the period of 1st of January 2015 to 1st of February 2018, and they have to complete at least 1 year of follow-up to be included in the study. We exclude patients who actually receive any kind of treatment within the last 1 year before they were recruited for the study, or those who have concurrent ocular vascular diseases. We managed to include 300 treatment naive patients, 300 treatment naive eyes from 202 patients. The median age was 60 years old, and half of our patients had bilateral eye involvement. When we look at the systemic comorbidities, of course, majority of patients has hypertension. It's quite well known in our population, and followed by the other chronic diseases. When it comes to the status of diabetic retinopathy, we have at least 1/3 of our patients who are actually having the proliferative diabetic retinopathy stage. And the baseline CST was 352 micrometer, and baseline visual acuity was about 0.33 Snellen decimal. That is about 6/18 vision. Now, let's look at the actual burden for our patient. As we can see, there is an increment. This is actually a cumulative number of injection, as well as cumulative number of clinic visits. Now, basically, if we do the comparison, as a start, we can see that the patient received a median of 6 injections in year 1, and at the end of year 4, they received 11 injections. But when you look at the number of clinic visits, the first year they have to come 10 times, so they have that 4 non-injection visits. But on the second year, they have 18 visits, 24, and subsequently 30 visits. When you look at the difference between the number of visits and the number of injection, we can see the burden increases with time. When we look at the ratio of visits, you can see even starting from year 1, at least almost half of their visits are non-injection visit. When it comes to year 2, you can see majority of their visits, more than half, are actually the non-injection visits. So this high ratio of injection to the number of visits may actually contribute to the high treatment burden, not only for us, but as well as for the patient. Of course, when we look at the response of the patient, most of them benefited from the injection, the treatment regime that we are doing for our patient. You can see the vision improved from 0.33 to 0.5 at the end of year 1, and continue to stabilize at year 4. And when we look at the CST itself, also there is definite improvement from 352, which eventually stabilized to the less than 300 micrometer. So when it comes to response of the treatment, yes, they do respond as expected, but when it comes to the burden to the patient and also the healthcare system, this is something that we are a bit worried. Now, let's look at how many of our patients completed the loading dose. We are happy, at least more than half of our patients completed a 3-monthly loading dose, and 1/3 did not manage to complete the loading dose within that 3 months. And when we look at the treatment discontinuation rate, This is the one that actually, among the things that we want to look at when we start to do the study. We can see 12% of our patients start to discontinue their follow-up or treatment by the end of year 1, which is not bad. But when we reach year 2, we can see at least half our patients did not turn up. And in year 3, it's even worse, almost 1/3. And by year 4, we are losing almost, most of our patients. Now, at the end of the day, yes, we help to improve their vision. We help to stabilize their vision. The OCT does improve, but the number of clinic visits is too high, which probably leads to the significant number of default rate in our case. So initially, we were very disappointed, but of course, this is not something surprising because this issue is just not a local issue. It seems to be the global issue, and it has been reported in many real-world studies that we are losing a lot of patients. Now, interestingly, there is this IRIS registry study, which was conducted within almost the same period as our study, 2015 to 2019, and they managed to recruit 190,000 eyes. So what they actually found in this study is, again, this study was actually looking at the discontinuation rate of patients who received the antivegf injection, and obviously this is also probably is a mixed kind of representation of the PRN and also the treat and extend, because this is also a retrospective study. So what they say is, you lost at least 1/3 of patients every single year. So either they stop treatment or they don't come back. So how do we help to improve the situation? Because we know the importance of having the treat and extend, the importance of continuation of treatment to stabilize the vision. Probably we just have to empower or enhance our education towards our patient, or towards our supporting staff, as well as to the our colleague. Now, maybe we can improve our follow-up system, set a reminder before the follow-up, or at the same time, we can also call the patient back again in case they miss the follow-up, and make sure they are well. Another important part is to make the treat and extend as the default mode of treatment rather than PRN. As we know, treat and extend helps to reduce the number of visits a lot more compared to the PRN basis. Now, with the emergence of new drugs, which stays in the eye a bit longer, probably this issue of treat and extend is not relevant in the near future. And yeah, probably we're looking forward to all these new drugs with a very high safety profile, with a better safety profile. Now, why treat and extend can be quite challenging, I admit it is not easy, because it's difficult to accept. For the patient itself, it's not easy to accept that they require the injection, even though the OCT is dry, even though the vision is good. I suppose it would be much easier if you sort of counsel the patient from the beginning, spend a bit of more chat time with the patient, give them the options. What I usually do is I try to, if they are quite educated, I actually try to give them the options of, you have two options. You can either go treat and extend or PRN, but treat and extend is the best. As long as we educate the patient from the beginning, importance of treat and extend, and this is what you're going to go through, and we are going to inject your eyes even though the OCT is dry. We are still going to inject your eye even though your vision is good. But if you do not agree, if you're not comfortable, and they're willing to come more frequent, then they will opt for the PRN regime. In our own setting in UKM, we have like 300 to 400 patients in one day. It is almost impossible to do that to every single patient. So probably what we have to do is we have to empower our counseling team. It's a take-home message for us in the university, looking at our results at the moment. And don't forget, we also have the options of switching to other antivegf, as well as other modality like a steroid treatment for DME patients. So at the end of the day, we try to individualize our treatment so that we can keep our patient as long as we can and give them the benefit of the treatment. Again, just to highlight, during this COVID period, the treat and extend is the best time to actually enforce to be enforced in our clinic, because it helps to bring the patient back a bit more later. So we have a similar suggestion proposed in our Malaysia guideline, as well as there was actually a paper being published by a group of our retinal physician, a so-called what we call the guideline to how to treat our DME patient for our Asian population. So when we look at the guideline, we can see that at the end of the day, they do recommend us to consider the treat and extend regime for most of our patients. Now, in summary, these are the causes of potential suboptimal treatment for our patient, which is the incomplete loading dose, extend injection and visit too early before the OCT normalizes, inconsistent follow-up among our patients, and also the high number of visits probably leads to the high default rate at the end of the day. So how we can improve? Of course, to optimize the anti-VEGF treatment regime. Don't forget the loading dose is very, very important, regardless of whatever anti-VEGF that you're using. The monthly loading dose is very important. Do not extend too early. And don't forget all the other alternative treatment that we have, other anti-VEGF as well as the steroid injection, and educate the patient as well as the family members before we initiate the treatment. And with that, thank you.